Good morning, friends. Good to see you again in such large numbers on this fine Sunday morning. I welcome you all. Those who have joined new today, for them, a brief description about myself. I am Dr. Agarwal, publishing GP Clinics, which is a CME journal for family physicians. It is being published for last 12 years every month. Today is our third webinar on the series on diarrhea when solid waste becomes liquid. The first one was on fever and second on cough last month. For your information, recordings of all the previous sessions is available on our website, gpclinics.in, and a summary of each session with Q&A, question and answers, is published in the printed issues of GP Clinics every month. Please note that the docislive.com is our own digital platform to conduct all our digital activities, including this webinar series. Before handing over the platform to Dr. YK Amdekar, I would like to mention few things which needs clarification. Many people have been asking us to send us the link before each webinar. Let me clarify that there is only one link, https://docislive.com, which is valid for all the 12 webinars. Those who join new have to register at this link, and those who are already registered have to just give their authentic email ID to log in. There is no Zoom-like link sent for each webinar. You just have to remember docislive.com. And for your information, as promised, we have dispatched August issue of GP Clinics complimentary to all those who have given their addresses on DocIsLive platform well in time. And secondly, last time there was some problem in searching the poll window where to answer the quiz being asked by Dr. Amdekar. So for your convenience, we have put the poll window just by the side of the video. You can see on the right side for your convenience, and the chat box where you can ask the questions just below the poll window. You just need to scroll down a bit to type your questions. I would like to emphasize also once again to all of you that please join our WhatsApp group docislive.com to get regular updates. Lastly, I request you to please give your valuable feedback for us to improve to serve you better in subsequent webinars. Feedback button is there just at the bottom of the chat box. Format of the program is the same again, an interactive case-based discussion to approach common symptoms to enable you to make a OPD or bedside diagnosis. Again, session summary with Q&A will be published in the next issue of GP Clinics. Those who have joined new, the speaker would be Dr. YK Amdekar. He will be there for the entire series. He is practicing for last 50 years and currently visiting consultant to SRCC Hospital, Mumbai. He has been the faculty to Grand Medical College, JJ Group of Hospitals, and Institute of Child Health, Mumbai. He has been the past president of Indian Academy of Paediatrics as well. So over to you, Dr. Amdekar, sir. Floor is yours.
Thank you very much, Dr. Agarwal, and good morning, all our friends. I think today you must have seen the title of today's webinar. Can I have the slides on, please? You can see that I have said diarrhea is when solid waste becomes liquid. So please keep that in mind. And as usual, we will start with a revision of basics and then go on to some interactive session, and then thereafter 8 different types of cases that you all are likely to be seeing in your routine practice. I think, next slide, please. When you talk about the basics, the 2 things are very important. Please note that anytime there is a change in the bowel pattern, which often causes frequency of stooling and even the consistency goes liquid, usually the patient is sick and also has a loss of appetite. But this is not always true. As the title goes, it is the solid waste becomes liquid. What does it mean? The consistency of the stool getting liquid is the reason why we call it as diarrhea, but often associated with frequency, sickness, and loss of appetite. Now, why does one get diarrhea at all? We often use terms indigestion without knowing what that really means. Technically, it is a maldigestion, which means abnormal digestion. And if the food is not digested, then it cannot be absorbed. And therefore, the result is diarrhea. Now, what is digestion really? Digestion is whatever we consume in food in the form of, say, proteins, carbohydrates, fats, minerals, etc. Each one of these items have to be further got into a smaller molecules. It's only those smaller molecules which can be absorbed. So digestion is from macromolecules to smaller molecules. That is called digestion. And if that doesn't occur, then the larger molecules cannot be absorbed effectively and you get diarrhea. If you digest the food well, that means the macromolecules like protein, carbohydrate, fats, etc. are now turned into smaller micromolecules. If they cannot be absorbed because the intestinal surface cannot absorb it for various reasons, you again get diarrhea. Sometimes the intestinal mucosa is irritated, inflamed, and it pours out secretions of fluids, and that causes a secretory diarrhea. Whereas at times, the food that you consume has a lot of insoluble items, like a large parts of sugar, for example, and it produces an osmotic diarrhea. At times, the intestines are in a hurry. There is a frequent contraction of the intestinal muscles, and that does not allow the food to be absorbed. And then also you get into diarrhea. This could occur out of local irritation or even sometimes eating too much and overload. You can imagine once you understand the basics, if you see a child with diarrhea, you look at it carefully whether you are dealing with maldigestion, malabsorption, or only the secretory or osmotic diarrhea, or sometimes it's just an intestinal hurry. Well, as usual, we like to first define anatomy of the disease. If you get a large volume watery stools, which often present with dehydration, it's generally an acute onset small intestinal disease. What about chronic small intestinal disease? It also has some semi-solid stools, but not so watery. They're variable in consistency and frequency, but being a chronic process, a child presents not with dehydration, but malnutrition. And what about large intestinal disorders? They usually produce not voluminous stool, it's a small volume stool, often with blood or mucus, and these children are very, very sick. So you could see how a diarrhea could be considered as either a problem of digestion, absorption, secretion, osmosis, or intestinal hurry, or it could be anatomically divided into a small intestine, large intestine, and acute or chronic. Well, common causes we all know are infection, the most common cause, but non-infective inflammation and also non-inflammatory causes, which are certainly not common, but drugs, of course, do cause diarrhea, enzyme deficiencies, and sometimes even the hormonal disorders like, for example, a hyperthyroidism, thyrotoxicosis could present with diarrhea. So keep all this in mind and don't jump to a conclusion that it must be an infection itself. Having said this, let's get to some interaction. Can I have the next slide, please? Now, this is your first interaction. I want you to define which of those four probabilities is wrong. Please note which of the following statement is wrong. Diarrhea may present as frequent watery stools. It may present as a single watery stool. It may present as frequent normal stools, or none of the above is right. Your time starts now. Well, there has been a mixed kind of a response, but I am happy that almost nobody said the last one is right. Please make a note. I told you that the title is When Solid Waste Becomes Liquid. So at times, a person may pass 2 or 3 normal stools, and that may not be considered as diarrhea in the right sense. This often happens in old age, for example, when the normal stool cannot be completely evacuated at one time, and the person needs to get an urge to pass stools more frequently than 1 or 2 times a day. But that is not diarrhea because he's every time passing a normal stool. So please make a note that out of all this, the consistency is most important, but often associated with frequency, etc. Let me have the next slide, please, for your another interaction. Now make a note. Which of the following statement is wrong? Maldigestion may be caused by disorders of stomach, liver, pancreas, intestines, or none of the above. Your time starts now. Again, quite a varied responses, but it means that all of you have got the right thinking process. I want you to take a note that the digestion starts right from saliva, if you like. Of course, the stomach, the liver, the pancreas, and finally the intestine, all of them participate in digestive process. Therefore, if you vaguely say, oh, I have an indigestion, it really means very little. And it could be that you are dealing with any part of the gastrointestinal tract, which also includes liver, pancreas, etc. This is just to make you aware that many times the disorder could be lying other than intestines, and you can still easily miss it as an intestinal disorder, though, of course, the commonest cause of diarrhea is an intestinal disorder. Having said this, let me get to the next slide. And the next slide shows how you approach a child of diarrhea after we have understood the basics. First, of course, confirm diarrhea. I've already told you how to do that. The first thing is your patient a healthy child or a malnourished child? Because the causes are often different. Then you want to know whether it's an acute diarrhea or sometimes an acute worsening of a chronic diarrhea. See, patient often comes to you saying that, oh, from last 2 days I'm passing 8-10 stools, but on direct inquiry, he could be passing such loose stools off and on even prior to the onset of acute diarrhea. So acute on chronic or acute is important to make out. Then, of course, we pick up the volume of stool, the consistency, the smell, the color. So many things are important to look at that. For example, if you are passing a watery stool with a lot of flatulence and an excoriation, you know that the carbohydrates are not getting absorbed, whatever the cause may be. Whereas if the stools are large, semi-solid, not too many, but very foul smelling, it could also mean malabsorption due to, again, varieties of reasons. I recall Dr. George Coelho, one of the first pediatricians of the country, was a professor emeritus when I joined pediatrics, and he could come once a week to kind of teach us. And in case of diarrhea, he would like to see the fresh pus sample of stool, because by looking at the stool, he could often give a probable diagnosis. Those were the days in early 60s where not too many investigations were available. But the point is, even macroscopically looking at the stool gives you some idea about what the problem could be. Of course, accompanying symptoms like fever, abdominal pain, tenesmus indicates that there must be inflammation. Vomiting indicates that there is also possibly the upper GI involved. Oliguria indicates there is possibly a dehydration. And of course, a lethargy or tiredness indicates that there is an effect even on the behavior of the child, that is, the brain may be affected. And finally, friends, take a note of this. Not every child of diarrhea has a loss of appetite, but few of them have very good appetite. Each of these points we will now apply in our analysis of cases and take a note of all these findings. What do you look at on clinical examination of a child of diarrhea? Of course, you do put your hand on the abdomen because that's where the parents also expect you to do because the problem is in the abdomen. But what are you looking at really? Far often away from abdomen. In abdomen, you only look at the abdominal distension because if the abdomen is significantly distended, it means you are likely to be getting into some complication in a child of diarrhea. It could be a paralytic ileus, it could be an intestinal obstruction coming after diarrhea, it could be hypokalemia. Okay, so take a note. Abdominal distension of significance in a diarrhea is often a complicated diarrhea. And of course, you look at tenderness, but you often look whether he's sick, whether he's dehydrated, whether he's in shock, whether he's drowsy, whether he has got a significant tachypnea, indicating he has a metabolic acidosis or he has an anal excoriation. Point is, you must examine in details far more than just the abdomen. Having given you all these basics and clinical approach, the next slide, please. Let's now get into some common cases, and you will answer every time what is your probable diagnosis. Now, this is a 2-year-old child who presents with acute onset of vomiting, which was followed next day by 7 to 8 watery stools, and he had mild fever. Vomiting stopped by the time the diarrhea started. Physical examination showed he was lethargic, he had a gaseous abdominal distension, he had signs of dehydration, and he had an anal excoriation. Now make a note of all these findings, and now I want you to vote for whether it is acute viral infection, whether it is an acute bacterial infection, whether it is an acute parasitic infection, or is it totally a non-infective inflammatory disease? Your time starts now. Let's see how it is going. Okay. So wonderful. I think in all previous 2 webinars, I realized that once I give you the basics and approach, majority of you start thinking very rightly. And I think this is the beauty of an interactive session. Most of you are absolutely right. It's classically a viral infection. And in a typical viral infection, small intestines are involved. They come with dehydration. And because the superficial intestinal mucosa has an enzyme called lactase, in such a viral infection, that is lost. And therefore, you have a carbohydrate malabsorption resulting from a viral infection. And therefore, you have a gaseous abdominal distension and an anal excoriation, which is a part and parcel of a carbohydrate malabsorption. But you're right, it was an acute viral infection. Wonderful. Let's get to the next case, please. The next slide shows you a similar problem. Now, please take a note very carefully. 2-year-old child presented with high fever, loose stools, 3-4 times watery for 1 day, and occasional vomiting. Let me reiterate what was the difference in the last case and this case. The last child did not have much fever, just mild fever. This child has got high fever. Last child had many loose stools with dehydration. This child has only few loose watery stools. And last child had a dehydration. This child does not have dehydration. He is sick looking. He is irritable. Last child was lethargic with dehydration. Make a difference in the note. Now I want you to again vote whether it is a viral infection, whether it's an acute bacterial infection, whether it is a parasitic infection, or it's an inflammatory bowel disease. Your time starts now. Well, majority of you have given a right answer that it's an acute bacterial infection. Okay. And please make a note. Why did you call it an acute bacterial infection? One, because this child is very sick. Now, sickness is a very subjective symptom, but I'm sure all of us who start practicing over years start smelling sickness. Somebody may have a large watery stool, but he's not looking very sick. A child with high fever looking sick. But why is this child getting a watery stool? And just small number. Do you think it's a small intestinal disease or likely to be a large intestinal disease? Now, I said that small intestinal disease has a many stools, large volume stools, and presents with dehydration. So is this a large intestinal disease? And I said, large intestinal disease comes with often sickness, but only few stools, but often with blood and mucus. Now, this child doesn't have a blood and mucus. Then why is it acute bacterial? Because he starts with very high fever, he doesn't have too many stools, and he has watery stools. Now, you can see high fever and only small number of stools, not large volume stools, small volume stool because he's not dehydrated. 3 points favor a large intestinal disease, but 1 point bothers you. Why has a watery diarrhea? Because watery diarrhea is usually a small intestinal disease. Point to make is this was an acute bacillary dysentery, and large number of you rightly spotted it out. But the point I want to make is that before the blood and mucus starts coming, you may have for a day or so only a few watery stools. Don't get on a wrong path just because it was watery, but high fever, sickness, and only small number of stools with small volume of stool, which largely favor a large intestine. You can almost bet that this is going to start with a little more mucus and maybe even blood over another day or two. And you are right. This was an acute bacterial infection. This was an acute bacillary dysentery. And you could have spotted out before dysentery comes. How wonderful. Dysentery means blood and mucus, and you spotted out a probable coming out of a dysentery in this child, even on day 1. You could have waited for a day or 12 hours, and you would have shown you of that. Often by the time blood and mucus come, this child starts with severe abdominal pain, etc. The point to learn is, the book picture is classically high fever, blood, mucus, abdominal pain, but a patient may not manifest all that on day 1. But even then, a good thinking can make you diagnose correctly, and you might have started an antibiotic on this child, right? Let's get to the next case. My next case is a little older child. He's an 8-year-old child who presented with moderate fever, loose stools, 2-3 per day, not too many, with mucus, abdominal pain off and on, and he has a poor appetite, and this is going on for last 1 week. Please make a note. Moderate fever, only few stools, but with mucus, abdominal pain, poor appetite, but going on for 1 week. On examination, I could not find anything at all. Now you want to vote whether it's an acute viral infection, an acute bacterial infection, an acute parasitic infection, or an inflammatory bowel disease. Your time starts now. Most of you have said it's an acute parasitic infection. You may not be totally wrong, but to a small point, yes, you are wrong. What do I mean by that? An acute amoebic dysentery may fit in typically on this situation. But the point I want to again highlight here, because we are largely talking about a pediatric patients, and often amoebic dysentery becomes chronic and more than acute. To that extent, not that you are wrong in considering this, but likely that this is an inflammatory disorder, yes. And it's also not likely to be bacterial, but there is a sickness. Now, moderate fever is rare in an acute amoebic dysentery going on for a week. So, some small points make you consider in such a situation that is more likely to be an inflammatory bowel disease. Whether you call it a Crohn's disease, yes, in children, the most common inflammatory bowel disease is a Crohn's disease. And this could very much be an inflammatory bowel disease. But again, you have started thinking fairly correctly. You are not much wrong when you call it a parasitic infection, but I gave you subtle points against a parasitic infection like an amoebic dysentery, more often chronic than acute. If acute, not lasting for a long time without complication, moderate fever, and all this rare in children makes it more likely to be an inflammatory bowel disease. But good, I'm quite impressed by your correct thinking, and I just want you to give us subtle, small differences that you start now thinking beyond, out of the box, as if said. Let's get to the next case. My next child is also again an older child who presented with loose stools 2 to 3 per day, large volume, foul smelling, grayish white for last 4 days. There is a mild abdominal pain, but poor appetite, and there is no fever. Now look at the small difference between the last 8-year-old child and this one. Both of them have only 2-3 loose stools. This child has a large volume stool and foul smelling stool. And also the color is changed. But he has no fever. The last child had high fever and he had a mucus and blood. So small differences, right? Take a note of all these small differences. On examination, of course, there was nothing. Again, to make a point that when you don't find anything wrong, it only means that mostly it is not a complicated problem. We said in a clinical approach, large part of physical examination tells us more what is happening beyond abdomen. And therefore, this child is localized to abdominal problem only. Now, this is the time for you to vote whether it has been a viral, a bacterial, a parasitic infection, or it has been some kind of a maldigestion. Now, the time begins for you. Excellent. Okay. I want you to keep a note on this. I put this specifically because of that. Okay. You take a note of a grayish white stool, which indicated very correctly that there is a fat malabsorption. But make a note, it is extremely foul. Now, when it is very foul smelling, there has to be something beyond a maldigestion. Again, a small point, but you are all right, absolutely right. But I want you to take at a little higher level that we said that an acute viral diarrhea, the rotaviral diarrhea, the first slide, first case, had also carbohydrate malabsorption because there was a gaseous distension and an anal excoriation. But it was secondary to an acute viral enteritis. Now, this child, because it is extremely foul, it might mean some infection. You know that if you have got a foul smelling sputum, oh, you have some chronic infection there. Or if you have a foul smelling ear discharge, oh, you have an infection there. If you have a foul smelling nasal discharge, oh, you have an infection there. So you have an infection causing maldigestion, but there has been no fever. So this is typically a giardiasis, a parasitic infection. But I will give you a full mark when you told me it's a maldigestion. It is a maldigestion, but in this kind of an interactive session, we can go one step beyond an average doctor. And you said maldigestion, correct, but the cause of maldigestion is also given in this foul smell, and that becomes a giardiasis. Irrespective of whether the stool shows giardia or not, you may not be wrong to treat it as giardiasis because this is a classical syndrome of a giardiasis, right? Good. Let's go to the next slide. My next case is a small child, 2-year-old. He has been a healthy child. Take a note. He presented with watery stools, 7-8 per day, mild fever for 2 days. Fever disappeared, but loose stools continued for next 10 days. Take a note. Healthy child, mild fever, large volume, watery stools. Okay, fever disappears, but the stools continue to exist for next 10 days, and the parents are worried. Sir, we came to you for loose stool, and even if the fever has gone, but the stools continue. On examination, you have nothing. I want you to vote whether this is a viral infection without complication, or whether it is a viral infection with complication, or whether it is a drug-resistant bacterial infection, or all of the above are possible. Your time starts now. So wonderful. Okay, I am impressed by a very practical knowledge of majority of you. Okay, and I'm sure that our children are in the safe hands of all family physicians. Okay, how wonderfully you said that this is without complication. What did you learn? Merely because some stools continue for a long time, you don't call it a complicated problem. What are complications of a viral infection? Possibly a paralytic ileus, a hypokalemia, abdominal distension, dehydration, shock, electrolyte imbalance, metabolic acidosis, or the subsequent problem with the CNS because of all this. This child had none of that. And this child has been healthy. So wonderful. What have you learned? If such a child comes to you and he is better, why is he better? Because he's looking better, he's playing well, he's eating well, but he still passes some loose stools. It only means that nature is taking a little longer time for intestinal mucosa to recover. And all that you do is you counsel the parent and give them a confidence that wait for a while. The nature is taking a little longer time to recover. And you so rightly said, This is an acute viral infection without complication. I'm so impressed. Let's get to the next slide, please. Now, this is even a younger child, infant, 8 months old. He presented with loose stools off and on for last 2 months. Remember, he did not have any problem in the first 6 months. The stools are watery to semi-solid. At times semi-solid, at times watery. They are greenish. There is no fever. Occasional vomiting. Child is sometimes irritable, but his appetite is good. Now make a note. One of the earlier patient had a foul-smelling and grayish white stool. We called it a giardiasis. This child has a greenish stool. So far, all our patients have had a poor appetite, but this child has a good appetite. Take a note, healthy child, good appetite, greenish stools, but going on for last 2 months. On examination, I find him a little irritable. He has got a little gaseous abdominal distension. He has a poor weight, but he has got a good appetite. Now I want you to vote whether this is a chronic viral infection. Is this a chronic bacterial infection? Is it a chronic parasitic infection? Or it is none of the above? Your time starts now. Good. You have some kind of a mixed response, but majority of you probably favor a chronic parasitic infection. Chronic parasitic infection is extremely rare at this age. That's number one. Second, any infection generally have a poor appetite. This has got a good appetite. Okay, so take a note of all this. And most important is the stool color is greenish. What do you mean by greenish stool? It means that the bile is coming into the stool, and that means the bile is not used. Nature doesn't produce more bile. Nature produces bile, which is expected to take care of digestion of the amount that we consume. But if you consume less, then the nature doesn't know you are going to eat less. The nature is producing enough bile. Now that bile is unused, so it comes down into the stool and you have a greenish stool. So, common cause of an infant with a greenish stool is a child is not getting enough nutrition. And all that this child, that's why this child has a good appetite. He wants to eat more, but he doesn't get more. That's why he's losing weight. The only other cause of greenish stool could be if there is a significant intestinal hurry, whatever the cause may be, then there is no time for bile to mix with the digested food, and therefore both the indigested food or malabsorped food comes out along with bile, but that is not common. The common cause of a healthy child with greenish stool is just inadequate intake of food. And why is he irritable? Why is he having loose stool? That bile is an irritant. If the bile is unused and remains so and passes through the whole intestinal tract, it causes irritation and therefore few watery stool. This child does not need any treatment, but what he needs is an advice and a good counseling for the mother to start something more than just the milk that she may be giving, and the stools would turn yellow and the stools will come back to normal. This is one example how a normal child may have a loose stool, but a greenish stool and a good appetite tells you this is not a disease but a semi-starvation. Let's look at the next slide, please. My next patient is again a little older child, 8-year-old, who presented with loose stools off and on for last 2 months. Take a note now. He has got loose stools off and on for last 2 months. He has no fever. He has no loss of weight. But he has got a good appetite. Okay, make a note. He has no fever. I'm sorry, he has no fever, but he has lost weight. But he has a good appetite. So, chronic diarrhea, no fever, and but having lost weight in spite of good appetite, he's eating well. On examination, I have nothing. I want you to vote whether this is a chronic parasitic infection, whether it is tuberculosis, whether it is a chronic fungal infection, or it is a malabsorption of whatever type. Your time starts now. Excellent. Okay, you have got the correct field. You had a child who was not taking enough intake of nutrition. He was having diarrhea but with good appetite. And here is an older child who has also got diarrhea, but he has got a good appetite, which means he wants to eat. What have you learned? It's an inflammatory problem that puts your appetite off. But when there is no inflammation in the system at all, mostly you have got a good appetite. And this is typically a malabsorption. Okay, good. I think you got it so right. And how important is to ask a child of diarrhea whether he's eating well or not. Okay, many parents will say, how can he eat, sir? He's sick. No, but occasional child could be eating well. And one another example of a hormonal problem is a hyperthyroidism, thyrotoxicosis. They have an excessive appetite, but they also have diarrhea and loss of weight. So you got it so right. Let me get you to the last case for a discussion. The next case, please. Now, this is another old child, 8-year-old, presented with abdominal pain and loose stools off and on for last 4 months. Oh, he has gone on for a longer time. His loose stools are at times with mucus, sometimes without mucus. There's 2 or 3 per day. There is a mild to moderate abdominal pain. He has no fever. He has no vomiting. His appetite is variable. Sometimes he eats well, sometimes he doesn't. But he has not lost weight at all. Take a note of this. Small differences here and there that I'm giving you. The previous child of a malabsorption did not have abdominal pain, telling you that there was no inflammation. Inflammation causes pain. This child has a small amount of pain. So there is some irritation occurring definitely, but it's not having any fever. So now, considering all this, he has not lost weight even when that, because some days he eats well, some days he doesn't eat well. Some days the stools are without mucus, some days they are with mucus. It's a variable, right? Take a note of all this. On examination, of course, there was nothing. I want you to vote whether this is tuberculosis, this is chronic parasitic infection, or this is an inflammatory bowel disease, or this is none of the above. Your time starts now. Most of you have said inflammatory bowel disease. Now, I did mention to you earlier that whenever there is an inflammation, one tends to have a poor appetite, be it infective inflammation or a non-infective inflammation, sometimes the malignancy causing inflammation, whatever the cause may be. So this is non-inflammatory. Okay, take a note of that. Again, though he has a variable appetite, that means on some days he is eating well, on some other days he doesn't eat. Same thing, loose stools are also variable. Some day they have mucus, some day they have no mucus, and there is no fever. So this child has not only no infection, but also likely no inflammation. Then why is he having an abdominal pain? Abdominal pain, therefore, is just an irritation of some kind. And don't forget that pain comes either from one side or it may come as a perception of the pain. Okay. Pain is of 5 types: inflammatory, vasogenic, myocardial infarct has pain, neurogenic, sciatica has pain, psychogenic, or referred. Any pain, you take care of these 5 things. And therefore, the correct answer to this was none of the above. And this is called an irritable bowel syndrome. The bowels are irritated. The obvious causes: the child is irritable, child is frustrated, child is depressed, child has some stress, and that has caused this irritable bowel syndrome. We'll not get into all the details of what is this, but the point I wanted to show in these 8 cases is that each one is a slightly different from the other, and you have done so wonderfully well. I wanted to put 1 or 2 cases which were a little unusual for you to also go a little beyond the average. And I'm sure that those who go for GP clinics, they want to keep on learning, updating. And those who attend such webinars want to learn more and more. And I must give you something more than what you already know. What you already know, you are revising. But what little you may not know or you may not have been aware of is what I want to impress on you so that you become every day better than yesterday. Having said this, let me get to the next slide and tell you that investigations have a very little reason to worry about in diarrhea. They're not helpful in acute diarrhea at all. They're useful in parasitic infection, yes, amoeba, giardia, etc. They're useful for fungal infection, but please make a note that only because the stool shows yeast, it's not necessarily pathological. Many yeasts are non-pathological. That's not the cause of diarrhea. Sometimes you can confirm inflammation because there are pus cells, red blood cells, and sometimes you might also see some fat globules in a fat malabsorption. But you can see that routine stool examination rarely helps you in acute condition unless you are looking at something very specific. Stool reducing substance is a useless test. Every acute onset loose stool will show some stool reducing substance. It has no meaning at all, and it does not make you change his diet or stop sugar, etc. It is only required for a chronic diarrhea which has been malabsorbing and malnourishing. So don't ask for a stool routine reducing substance, though today pathologists always do that, and you and me always get confused because they write, yes, reducing substance present. Forget that. Similarly, stool for rotaviral antigen can almost confirm the diagnosis, but it's not worth a test and spending money for it because your diagnosis of our first case was a classical rotaviral diarrhea and you do nothing but just take care of hydration. Stool culture is almost never required. And if I ask you how you collect the stool aseptically, you will start wondering how to collect the stool aseptically. So it is not a common test at all, and forget about it. Specific test for malabsorption, of course, is the subsequent problem of a super specialty, and so also mostly the imaging is reserved for only the super specialists. What does it mean? You and me really don't have to investigate majority of cases unless you are looking for a fungal or a parasitic infection or you are looking for some malabsorption. Let me give you the last interactive slide. The next slide, please. Now, all of us know that we treat diarrhea symptomatically also, and of course, treat the cause of diarrhea. And I've given you 5 types of problems that you may choose from. And therefore, now you tell me what has been your drug of choice for symptomatic control of diarrhea. Not a curative problem, not specific problem, but just symptomatic control. The drugs used are loperamide, racecodotril, bismuth, in earlier days, Or you could use any of the above, or you want to use none of the above. Your time starts now. So wonderful. Okay, I think that's absolutely so correct. In adults, sometimes people use all such drugs like loperamide, for example. Okay, but take a note that majority of these drugs may cause more harm than good. And what are we worried about this symptom of diarrhea? Either it gets well by itself or you have to find the right cause. And all that you do is during that time, you just hydrate the child. And therefore, the next slide, please, tells you a basic problem of how you treat it. We already said that all that you do is not routinely recommended at all. Okay. You maintain hydration and electrolyte balance, and that's where the ORSs come in. And most important is continue the same diet. There is no need to change the diet in an acute diarrhea. Let the child eat what he normally eats. If he has an appetite, he will eat. If he has no appetite, he will not eat. That's it. Antibiotics are only for invasive bacterial infection. What is invasive? One that has a mucus and often blood, like a dysentery, but not otherwise. Zinc is often now considered as one useful drug in case of diarrhea, but it's largely useful for a community which is largely undernourished because this mineral is often lacking in our diet, like many other minerals. And therefore, it has been shown that if in a little malnourished child, if you give zinc, the diarrhea comes under control little quickly because they are often zinc deficient. Well, you could use it for anyone, whether it is useful or useless, but it is largely required for an undernourished population. Is probiotic useful? Absolutely not. There is no recommendation for use of probiotic even in chronic diarrhea. So forget probiotics. Absolutely. And most important is in diarrhea, you need a good follow up because you don't want the child to come with diarrhea again because many of them have a preventive problem. Their hygiene is at fault or their diet is at fault. And therefore, your treatment is complete only when you also give a lot of preventable advice because diarrhea is often coming. My next slide just summarizes all that we discussed. The next slide, please. You have said that detailed history gives you near correct diagnosis, and the examination is only to look for complications largely. Tool microscopy, useful for very specific situation, and ORS and zinc is the probable treatment for watery diarrhea. Many get well by themselves, but antibiotic for a very selective issue. I would say chronic and recurrent diarrhea is not our view of presentation today, and that is largely for referral because you need a lot of tests and a lot of other things to do well. Well, I stop here, and if Dr. Agarwal has had some questions, I could answer within the next 5 or 7 minutes that we have. Back to Dr. Agarwal, please.
Hello. Hello. I'm audible?
Yes, yes.
Okay. So there are a lot many questions. Let us take few of them. I think one is Dr. Deepak from Nagpur has asked role of pre-probiotic in diarrhea. I think probiotic you have already answered. It is not recommended, but he's asking role of prebiotic in diarrhea. What is
I
that?
think largely, I don't say there is no rule at all, but I mean there is no recommendation to use for routine cases. For a chronic diarrhea, it's a different story. After all, your grandmother knew that in diarrhea she would give, say, a curd and rice. What is curd? Curd is a probiotic, a prebiotic. Okay. And therefore, the science, modern science has evolved out of a traditional wisdom of Indian kind and now put it in a form of a drug and large time. Lastly, probiotics are of so different types, so we are not sure which is the best type for which type of a patient. And with all this confusion, I think the probiotics are more marketed rather than more useful. But probiotics are safe. So if you think that harmless medicines could be tried, I have no objection. But if you feel that harmless is also useless, then why make them spend? Then that's your choice. That is my answer about prebiotics, probiotics, etc. And now, if you give antibiotic, then possibly you need a probiotic. But then why give antibiotic for diarrhea? And if you give antibiotic for a small duration of 5 or 7 days, you don't need a probiotic or a B complex or whatever. So that is the answer in nutshell. I'm sure I have a very extreme view of everything, but I bet that is the absolutely scientific academic view, not mine own. And therefore, yes, you can use sometimes in your practice. If you have found useful, you use it, it's harmless.
Okay. Dr. Sachin from Amravati is asking how to distinguish infective from non-infective diarrhea.
Well, it's not easy to differentiate acute infective from non-infective inflammatory diarrhea because inflammation symptoms and signs are common. But most of the acute infection are short duration problem. Most of the non-infective inflammatory disorders, like an inflammatory bowel disease, are a little long-term problem. That is number one. If it's an acute infection, you have already decided how to differentiate acute viral from acute bacterial. Acute viral is a small intestinal problem. Acute bacterial is a large intestinal problem. Whereas an inflammatory bowel disease could be right from small to large intestine. So could have any of those symptoms. Generally, an acute bacterial infection or viral infection are of a very acute onset. Inflammatory bowel disease is a bit of a subacute onset going on for a long time. And therefore, to begin with, on the first 2 3 days, both may look similar, but an acute bacterial infection looks very sick. An acute viral infection often does not look sick at all, even if it's dehydrated. And an inflammatory bowel disease, that is a non-infective inflammatory disease, often looks not very sick, but not very fine also, like a viral infection. Now, these are all subjective feeling, but I'm sure all of you have been practicing for 20, 30, 40 years. Start getting that kind of a feel, and therefore you go by that. If you examine a stool of an acute bacterial infection, you will find a lot of macrophages, pus cells, red blood cells. In a non-infective inflammatory disorders, you will not find many of them, but only a small of them. These are small difference, but yes, on the first 2 3 days, it's not possible to differentiate at all. But very sick child, acute bacterial, moderately sick child or mildly sick child, inflammatory bowel disease, and hardly sickness is a viral infection.
Okay. So the next question is, can there be an empirical treatment of diarrhea?
No, there is no empirical treatment of diarrhea at all. In fact, I would say empirical treatment is only possible when you have a life-threatening situation. Like in an ICU setting, when somebody is sinking, I don't want to be rational in my thinking because rationality at that time is irrational. I want to save life. So I don't mind using not one, but even two antibiotics, or maybe antiviral, maybe antimalarial, everything under the sun, because my immediate aim is to save life. But in non-life threatening situation, there is no reason for an empirical antibiotic therapy or a empirical specific therapy. And one classical example, not in case of diarrhea, but tuberculosis, for example, at times you cannot prove tuberculosis, but if you wait for 2 3 weeks and try every method of proving the diagnosis. But if you fail, you might consider on a strong clinical basis that you would give an empirical anti-TB treatment. But remember that don't take this as a routine thing. Empirical treatment has no reason to follow to begin with, but in real practice, it is not easy to prove every point a diagnosis, and sometimes you may have gone out of your patience, but having tried every bit of how to prove your diagnosis, if you have failed even after a genuine attempt, then write an empirical antibiotic. But before writing that empirical antibiotic, write 4 lines why you consider it as a bacterial infection needing an antibiotic even without a proof. You must be able to write 4 things. In other words, you must be able to kind of convince your own conscience. It's like when I'm teaching the student, if his student says, I'll give an empirical antibiotic, I'll say, yes, you may be right, but tell me why. And if he cannot tell me why, then he has not understood the problem. In routine solo practice, who is going to ask us that question? Our own conscience will ask that question, and you will answer to your own conscience. If you keep that in mind, mistakes will occur. At the end of 55 years of practice, I continue making mistakes. But I take care of learning from those mistakes, and I hope that I don't repeat the same mistake. But in life, there are so many mistakes to do. Why should you repeat any mistake? So I think refrain from this. Yes, sometimes you may be tempted to do this. Keep your temptation away. Give a reasoning to your own conscience. And even then, if you make a mistake, you learn from that mistake. Back to Dr. Agarwal.
There are a lot many questions. Okay, let us take one last one. And I think it will require a long answer. So better we keep it for publication in GP clinics.
Sure,
and
sure,
just
sure,
the question.
sure.
What is the differential diagnosis based on stool, color, consistency, frequency associated with mucus, blood, etc.? I'm sure it will require a long answer, and we
sure. I think I will do that.
Yeah. So here we come to the close of today's session. So thank you, Dr. Amdekar, sir, for this wonderful session, which was full of information to help doctors in plugging in minor gaps in their clinical judgment, if any, in managing a very simple but common problem such as diarrhea. We hope this interactive session would have made learning interesting to help empower your practice. On behalf of GP Clinics and docislive.com, I thank all the doctors who have attended this session. And it's quite encouraging to see that we are having more and more number of attendance with each passing webinar. And please note the date for the next webinar. It will be on 18th September, Sunday, 11 a.m. same time. The topic would be constipation, gut in slow motion. 18th September, 11 a.m., constipation, gut in slow motion. I hope you all must have noted it down. So thank you once again to all of you. Good day.
Good day to all of you.